Oh my gosh, this is home to me. Thank you so much for having me here. This is my third year in a row at this amazing meeting. Thank you, Jessica, for having me. I know you are my biggest cheerleader. So thank you, all of you. And I think I'm going to become an honorary member of the AOCA. So when Jessica called me about several months ago, it's almost 10 months ago, and she said, Anu, this is a brand new topic and everybody is lost. And there was no literature at the time when she asked me to do this talk. This is a brand new talk that I was starting to prepare, and I told her, I have no idea what I'm going to do because there's nothing around perioperative use. But luckily, over the last several months, we have a lot more data than we used to several months ago. So I'll get started, and we can have this as an interactive session. We had a PBLD this morning. We had a very amazing discussion. So feel free to actually raise your hands and make it a more interactive session if you wish. I have no conflicts of interest, and let me see if this mouse works, but I just want to put this out there as to the different definitions of obesity. Underweight is a BMI of less than 18.5, overweight is 25 to 29, more than 40 is obesity level 3, and then severe obesity is more than 50. So for this talk, our learning objectives will be to learn a little bit more about weight loss surgery, because while we are going to talk about semaglutides, we are also going to talk about the implications of bariatric surgery. The weight loss medications, especially the ones that have been introduced in the market over the last couple of years, how are these semaglutides different from all the weight loss medications that have been FDA approved for more than a decade? And why, as anesthesiologists and perioperative physicians, should we care about these? So just to give you a background, adjustable gastric bands have already become a thing of the past because they are not a very effective way of losing weight over a longer period of time. So currently the only two major surgeries that are in use are vertical sleeve gastrectomies and Roux and gastric bypasses. And sleeve gastrectomies is where a part of the stomach is actually dissected and a very small pouch is created, so which is a vertical pouch, which is why it's called a sleeve, which reduces the amount of volume the stomach can hold. Oops, this went back. Let me go back. While in Roux and gastric bypass, the stomach is resected, but then the stomach is connected to a loop of the small intestine. And the Roux and gastric bypass is just a more effective way of losing weight compared to sleeve gastrectomy. Now, what are the mechanisms? Now, we might think it's just a mechanical thing, that you're reducing the volume of the stomach so the stomach can hold less amount of food, and that's why patients cannot eat much more, which must be the major loss. So yes, gastric restriction is definitely a major mechanism by which the patients lose weight. It limits the amount of food a patient can have at one sitting. However, if this was the only mechanism, patients would be predicted that, these patients love their foods, obviously, so they would increase the caloric density and the frequency, and they would regain weight. The second mechanism might be dumping, which includes just the feelings of nausea, flushing, bloating, faintness, fatigue, and diarrhea when these patients consume foods with high sugars. And so it severely limits their intake of, sorry, this is very sensitive, severely limits their intake of sweets or pure sugars. However, that by itself also does not necessarily explain the weight loss. Is it malabsorption, just significant malabsorption of the macronutrients, or is it actually a neurohormonal cause? So there are a lot of neurohormonal changes that occur with weight loss, and there are multiple hormones that come into play, like ghrelin, insulin, leptin. These are the main three hormones, but then there are other hormones that I'm going to talk about too. So essentially, when there is fat loss, there is a reduction in fat cell mass, but then there are all these compensatory neurohormonal changes that will reduce the energy expenditure and increase the food intake just because of neurohormonal changes. And there is, in not a long time, there is restoration of the fat cell mass back again, which is why people are always on yo-yo diets, right? They lose weight, but then the body starts compensating hormonally to all those weight loss processes, and there is weight gain back again. Now, I want to talk to you a little bit about the gut hormones. And there are many different gut hormones that play a role in hunger, satiety, meal size, meal frequency, insulin sensitivity, and insulin secretion. We know that insulin is an anti-inflammatory hormone, and hyperinsulinemia and insulin resistance is what creates a pro-inflammatory state. Now, there is release of cholecystokinin, secretin, and GIP, and mortallin. Now, these are mostly hormones that will work on the duodenum. However, the stomach actually itself produces a lot of hormones which are very essential in terms of regulation of hunger. The main one is ghrelin, which increases hunger and also causes a growth hormone release. Gastrin has almost no role in terms of hunger, but it produces acid secretion. Insulin and glucagon are the most important in glucose homeostasis. Then there is the pancreatic polypeptide, which works on gastric motility and satiety. So it's really important to have that polypeptide available to have increased satiety. Then there is the amylin. Now come the GLP-1 and the GLP-2. What does GLP-1 do? It actually improves satiety and incretin activity. So it is extremely important in gastrointestinal motility and growth. So the thing is that when the GLP is secreted within the body, the effect lasts for only a few seconds. And so there is satiety, but then that effect goes away. Then there is the oxyntomodulin, and then there is the PYY, or peptide YY, which is also a satiety-producing hormone. So in terms of BMI and weight change, for different types of surgeries, the effects are different. For gastric banding, after 2 years, gastric banding doesn't work. So most of our data is for the first 2 years. However, for the Roux-en-Y gastric bypass, the change in BMI from 50 to 35 lasts over several years. As you can see, the effect of bariatric surgery is long lasting, and it lasts for 4 to 5 years. So the percentage of weight change, is by several, like 20 to 30%. As you can see, there is up to 66% have major weight loss at 4 years after surgery. There is a lot of inter-individual weight loss variability, as you can see, in between year 1, year 2, year 3, and year 4. The weight loss percentage is anywhere between 10% to 50%. So you'll see some patients who've lost like hundreds of pounds of weight, while the others might have lost 20 to 30 pounds, but that is also still very important weight loss. Now, ghrelin is a hunger hormone, and it's mostly produced in the stomach. It's in the gastric fundus. It actually increases appetite and food intake and reduces insulin sensitivity. So whenever we eat a meal, the levels of plasma levels of ghrelin go down, and plasma levels of ghrelin increase after a diet-induced weight loss, which is why when we induce a diet-induced weight loss, we still continue to feel hungry. And it also produces some counter-regulatory hormones. However, if the patient undergoes a bariatric surgery versus diet-controlled weight loss, the levels of ghrelin stay down for years because it's produced in the fundus, and part of the bariatric surgery is that we remove the fundus of the stomach. So the hormone, so it's not just the mechanical change, but it's the neurohormonal changes that are produced by removing the part of the stomach that is responsible for secretion of all of these hormones, which is why the weight loss stays for so the red bar is year 4. So the weight loss with both gastrectomy, sleeve gastrectomy and gastric bypass lasts up to 4 years at least, and we have much more long-term data now, and we know that it stays for several years. Now, peptide YY is a satiety hormone. It's produced in the ileum and colon. So while in sleeve gastrectomies, we don't mess with the ileum and colon at all, but in gastric bypass, we do. So that is secreted postprandially in proportion to the calorie content of the meal. And cleavage of PYY produces a satiety factor, which also reduces gastric emptying and improves insulin sensitivity. Now, coming to GLP-1, when there is a subcutaneous infusion of GLP-1, oxyntomodulin, which is another hormone that's produced in the stomach, and PYY, to achieve postprandial levels that are similar. So these are not patients who have had gastric bypass surgery, but when you the amount of hormonal change that happens after gastric bypass, if you give the same an amount of hormone subcutaneously to patients, there's about a 32% reduction in food intake. So, but you have to give continuous infusions of these different hormones. And again, this is another slide that shows that PYY also continues to be reduced up to 5 years after surgery. Now, GLP-1 modulates numerous functions in humans. It's secreted upon ingestion of food. It promotes satiety and reduces appetite. It also reduces postprandial glucagon secretion by working on the alpha cells of the pancreas. It reduces glucagon. This reduced glucagon also reduces glucose output by the liver, and it helps to regulate gastric emptying. It enhances glucose-dependent insulin secretion. So when GLP-1 is substantially increased after all types of bariatric surgeries, and it stays up for several years. Again, this is 6 months, 1 year, 3 years, and 4 years. So GLP-1 changes after sleeve gastrectomies also, and the Roux bypass also. This is when you produce a blockade of GLP-1 and PYY after Roux. So after a patient has undergone bariatric surgery, if you block the GLP-1 and PYY, it will produce a 20% intake in food intake. So what I'm trying to say is that these hormones are extremely important in the weight loss process instead of it being a mechanical issue. And this paper was just published this month, actually, in JAMA, that suggests that temporal changes in obesity-related medication after bariatric surgery are much more long-lasting versus no surgery for obesity. So while many people think that semaglutides are going to bring this revolution that may stop bariatric surgery from happening, it's unlikely, because the effects of surgery are last for way longer than just these hormonal changes. And also, sweet cravings are reduced for many, many years after gastric bypass surgery. These are just slides that show you that GLP-1 continue to be reduced for 1 year after the procedure. So does PYY and GLP-1. This is a repeat slide about the infusion of GLP-1 and oxyntomodulin. So whenever there is weight loss, whether it's through diet or through bariatric surgery, the mechanisms are completely different. And you can see that hormonal changes are in completely opposite directions when it's with diet alone or bariatric surgery alone. And homeostatic mechanisms actually come into play when it's just diet versus bariatric surgery. Um, there is a much greater weight loss with Roux-en-Y versus sleeve gastrectomy, and you can see and they are all because of the changes in neurohormones. Now, coming to anesthesia part of it. So there were showstopper obesity drugs that have stunned researchers because weight loss in obesity has been a topic of controversy for so many years, and we've been looking for this showstopper drug that would work for everybody and people can still eat what they want and still lose weight. This is the timeline for the different medications that have been introduced over the time. So researchers actually found back in 1995 that the hormone leptin helps to keep the mice lean. In about 2000, they actually found this glucose-dependent insulinotropic polypeptide. Exenatide was the first drug that was used for type 2 diabetes, which is a GLP-1 receptor agonist. And it was in 2014 that FDA approved Saxenda, which is a GLP-1 agonist for diabetes. And it was in 2017 when semaglutides like Ozempic were introduced. And then only in 2021, Mounjaro was also approved for weight loss. And just before Mounjaro was approved, there was approval for Wegovy. And the difference between Ozempic and Wegovy is that Ozempic, the doses are only available up to 1.7 milligram. For Wegovy, the doses up to 2.4 milligrams are available. So you have to be careful. Generally, the way endocrinologists start patients on these medications which is why it's important to know whether the patients are in the early phase of their weight loss or later phase, because in the early phase, they are on very small doses of medications. They're generally started at 0.25 milligrams or 0.5 milligrams, and they are increased almost every 4 to 6 weeks to the next level, and they're only increased by 0.25 to 0.5 milligrams. So they start on 0.25, go to 0.5, go to 1 milligram, 1.7 milligram is the next one, and Wegovy stops at 1.7 milligram. Ozempic stops at 1.7 milligram. And if the patients are at their maximum, appetite suppression, then they can just continue at 1.7 milligram. Or the endocrinologist would switch the drug to Wegovy, which goes up to 2.4 milligrams. So we have to pay attention what drug they are on and how much dose they are on, because the higher the dose leads to higher the appetite suppression and the other effects that we're going to talk about. So these are the different GLP-1 agonists that are available. Trulicity, which is once a week subcutaneous injection. Saxenda or liraglutide, it is also once a day. It's a once a day subcutaneous injection, so people take it every single day. Semaglutides are Ozempic, Wegovy, and others, which are once a week a subcutaneous injection. And now we also have an oral semaglutide available, which is a once daily oral injection. And patients have lost anywhere between 15 to 35 to 40% weight on these medications over time. And 86% of the participants lose at least 5% of the weight. So if they are like 100 kilos, then they have lost about 5 kilos of their weight. Now, like GLP-1 hormone, these medications promote insulin secretions from the beta cells and reduce glucagon secretion. They have a very long half-life, and I have to apologize to one of the participants who was here this morning who asked me about long half-life. What was their half-life? It's about 155 to 184 hours compared to the GLP that is produced in the body, which is only 1 to 2 minutes. And because of its effects on the stomach, it actually reduces gastric motility. It produces symptoms like nausea, vomiting, diarrhea, and reduced GI motility, which is why we cannot apply our standard NPO times to these patients. Our standard NPO times are 2 hours for liquids, 6 hours for light meal, and 8 hours for heavy fatty meals, right? When you apply those standard NPO guidelines to patients who are taking these medications, you will find that there are gastric contents in the stomach. So this was one of the first papers published in New England Journal of Medicine that is just talking about the amount of weight loss and causing the popularity, because 90% of the patients will lose between 5 to 10% weight that lasts for several years. So what are the unanswered questions with GLP-1 agonists? Is the perioperative semaglutide use associated with a higher residual gastric content? How long should we interrupt them? And what is the ideal or safe preoperative fasting interval for using these drugs for elective procedures? We cannot control emergency procedures, and any patient who's on semaglutide who presents for emergency procedure has to be considered full stomach, has to be given RSI, and given the severity or the amount of food that can be expected in the stomach, I think we should give a special precaution to the patient and his family that the chances of aspiration of not just liquid content but solid content is much higher in these patients, especially under emergency conditions, which leads to a much higher morbidity and mortality if aspiration does occur. So there is a strong correlation between presence and quantity of residual gastric content and delayed gastric emptying. We know that patients who have gastroparesis or slow gastric, like in terms of trauma or obesity, whenever there's reduced gastric emptying, there is increased gastric content. Essentially, increased residual gastric content is just a surrogate for gastroparesis, which may be temporary or permanent gastroparesis. And that's what these drugs do. They produce temporary or permanent gastroparesis. But there are several reports. If you look at magazines, the social magazine, the National Enquirer, you will find people complaining that even after weeks of stopping these medications, they are continuing to have nausea and vomiting and are unable to retain any foods, which suggests that there may be a much prolonged gastroparesis even after stopping these medications. So normally, patients who are not on these medications, they looked at a large study of 85,000 patients, and there's about a 3% incidence of retained gastric food after appropriate NPO. And normally the aspiration rate is about 1 in 2,000 to 3,000 procedures when patients are not on these medications. We don't know the full scope of the effect of these medications right now, because all we have is small studies, retrospective, and case reports. So I'm going to present whatever data we have available now. So this is one case report that was recently published only a month ago that suggests that, of course, we should proceed with caution. And they looked at the effect of semaglutides on residual gastric solids, because it's the solids that are more harmful, on gastric ultrasound. And this one is a prospective study in volunteers. So this is not patients, this is volunteers who are not obese, but they were started on semaglutides. So gastric ultrasound was used to evaluate the presence of solid gastric contents in both supine position and lateral position after 8 hours of NPO in patients taking GLP-1 agonists versus controls. And a second ultrasound was done 2 hours after drinking 12 ounces of fluids. Again, these are non-obese volunteers. About 20 volunteers were enrolled. And in supine position, 70% of the patients had gastric contents, and 10% of them had solid gastric content. And these are the pictures. They divided it between low volume, medium volume, and large volume. And you can see, this is an endoscopic study. This is not the ultrasound study. So my slides are a little bit. So I'm going to go back to another slide. So this is a retrospective analysis of patients undergoing upper endoscopy, where they actually looked at elective upper endoscopy. The patients were recruited between 7/20/21 and 3/20/22. They had standard NPO guidelines, 2 hours for liquids and 8 hours for solids, and the primary outcome was residual gastric content more than 0.8 mLs per kilo. All of the gastric content was suctioned out during endoscopy into a graduated container, and it was visually estimated as small, medium, and large. And this is a picture of small, medium, and large. And presence of ongoing digestive symptoms was also noted. So you can see that there were 33 patients who had semaglutide, who were on semaglutides, and about 371 patients who did not have semaglutides at all. And out of the 392 patients, all the patients, 392 patients had deep sedation, while 12 had general anesthesia. And 33 patients who were on semaglutides showed increased gastric content if the semaglutide was used within 10 days of endoscopy. However, if it was interrupted for more than 11 days, there was no increase in residual gastric content. Also, if you looked at the volume, the content was small in about a quarter of the patients, it was medium in another quarter of the patients, and large in about 48% patients. Younger patients were more symptomatic, and one patient of these actually aspirated. He was a 67-year-old male with hypertension, gastric bypass, and his last dose of semaglutide was 11 days before. So there will still be a small subset of patients who, even though they have had stopped their semaglutide 11 days before upper endoscopy, and he was NPO for 12.4 hours, and he had no symptoms at all. So there will always be outliers even after 11 days. Residual gastric content of solid food was about 4.6% with semaglutide interruption, and 5.7% when they were continuing to take the medication. The authors concluded that the perioperative use of semaglutide was associated with a prevalence ratio for increased gastric contents of 5.15. So these patients had 5 times higher chance of retaining their gastric contents. Now, the 85,000 patients that I was talking about, in the other study, the odds of residual gastric contents with type 1 diabetes was only 1.7. With type 2 diabetes, it was less, 1.4. With structural foregut abnormalities, the odds ratio was 2.6. And with gastroparesis, it was 4.8. So when patients take semaglutides, their risk for residual gastric content is the same as with gastroparesis, which increases their odds by about 5 times. Now, this is another case report that I found interesting. This was a 31-year-old patient who had type 2 diabetes, BMI of 45, and he was on a very, very small dose of semaglutide. So this was very early on after he started the semaglutide that he came for endoscopy. Now, sedation was given with lidocaine and propofol, and 150 milligrams of propofol was given. And when the endoscopist put the scope in, this is what it looked like. So this is when the semaglutides were not stopped. There was a lot of solid gastric content. So they went ahead and aborted the procedure and asked the patient to return in 7 days. After 1 month. Return after 1 month, but stop the semaglutide for 7 days. But they also asked the patient to be NPO for solids for more than 36 hours. So the patient actually took no solids. They were only on liquid diet for 36 hours. And this is the second endoscopy, and the stomach was completely empty. So this may be one of the considerations we may have to consider and remember, this patient was on a very tiny dose of semaglutide. So if your patient was on 2.5 milligrams, we don't know if his stomach would have still looked like this after 7 days of stopping and 36 hours of liquid only. There's another case report of semaglutide associated with intraoperative pulmonary aspiration. There is a 42-year-old with Barrett's esophagus for upper endoscopy and ablation of dysplastic mucosa. He was on weekly injections of semaglutides for 1.7 milligram, but only for 2 months. He was NPO for 18 hours, and when they suctioned his stomach before endotracheal tube was placed, there was substantial solid and liquid material in the stomach. So they decided to tube him, and after tubing, they found food in the trachea and the bronchi. Luckily, they were able to still extubate him 4 hours later, and he remained asymptomatic. But the amount of solids found was not really mentioned in this. So there is definitely delayed gastric emptying after these medications. Also, there is rapid tachyphylaxis at the level of vagal nerve activation, which is what produces the prokinetic movement in the GI. And for patients who present with severe GI symptoms like nausea, vomiting, abdominal pain, bloating, clinicians should consider delaying elective procedures. If patients did not hold their medications per recommendation and have no symptoms, then they should be treated as full stomach still because they have continued to take their medications. So these are the ASA suggestions. Now remember, these are not guidelines, these are not recommendations. These are just ASA coming out and saying, hey, we've noticed a lot of issues with these drugs, and this is what we suggest. And that's because they cannot really give guidelines because there's not a whole lot of data. So they are recommending that if the patients are on daily oral dosing, that oral dose should be held on the day of the procedure. If they are on weekly subcutaneous dose, a hold for 1 week prior to the procedure, and last dose should be 2 weeks ago. They also mention consider aspiration risk if patients are symptomatic for nausea and vomiting. And for diabetics, consider alternative medications for hyperglycemia management, because remember, if you're stopping them for more than 1 week, and if they are on semaglutides for hyperglycemia management, then now they have nothing on board. So probably they should go on oral semaglutides for that 1 week, for that second week, and then the oral semaglutides can be just stopped on the morning of surgery because the recommendation is 1 day only. Again, all these recommendations should be taken with a grain of salt because we really don't know what the effects are. So ideally, in my mind, we should stop these. So if today is Monday and their surgery is scheduled on Monday, the first ASA recommendations were like stop 7 days in advance, which means they could have taken their medication last Monday. But then they came up with a second advisory that maybe they should stop 2 weeks, which means they should have taken 2 Mondays before that procedure. These were the first recommendations that were published in the ASA Monitor, where they said patients on daily dosing should stop on the morning of, and patients on weekly dosing should just stop a week before surgery. So this was the Monitor publication that came a little bit before the recommendations in the news by ASA. And this suggestion is irrespective of the indication, whether they are on these medications for type 2 diabetes or weight loss, or the type of procedure or surgery. If GLP agonists are prescribed for diabetes management, then consider consulting an endocrinologist for bridging that anti-diabetic therapy to avoid hyperglycemia. So these are the ASA recommendations. Again, they are not guidelines. So if on the day of the procedure, you find out that the patient is on semaglutides you didn't know before, and if the patient has GI symptoms like severe nausea, vomiting, retching, abdominal bloating, or abdominal pain, consider delaying elective procedures and discuss the risk of potential regurgitation and pulmonary aspiration of gastric contents with both the surgeon and the patient. If the patient has no GI symptoms and the GLP-1 have been stopped as recommended, then just go ahead and proceed with the surgery. Now, if the patients have no GI symptoms, but the medications have not been held as recommended, then proceed with full stomach precautions or consider having a gastric ultrasound if possible, and if you are proficient with the technique. If the stomach is empty, then proceed as usual. If the stomach is full, or if you cannot do a gastric ultrasound, then consider delaying or treat the patient as full stomach and manage accordingly. Discuss the risks of regurgitation and aspiration. There's no evidence to suggest the optimal duration of fasting for patients on GLP-1 agonists. Therefore, until we have adequate evidence, we suggest following the ASA fasting guidelines, which I really don't know what that means, because we should recommend fasting guidelines that are way longer than the standard ASA guidelines. Ideally, they should be NPO for solids for 18 to 36 hours. That is my recommendation, and that's not something we do right now, but something that we should probably definitely consider doing. This was a paper that me and one of my colleagues published a few months ago about analysis of ERAS for bariatric surgery and what is the perioperative risk in patients who have undergone bariatric surgery for aspiration. So previous bariatric surgery definitely creates a higher risk for peptic ulcer disease, GERD, and esophageal motility disorders. When it's associated with central obesity, the odds ratio is about 1.4. Interestingly, severe obesity is associated with asymptomatic acid reflux. So we recommended that all of these patients who've had bariatric surgery and are presenting for another surgery after that should receive a combination of prokinetic agents like metoclopramide, H2 blockers, and non-particulate antacids like Bicitra. So my personal practice is that any patient who comes after bariatric surgery, I do give them 20 milligrams of metoclopramide because 10 milligrams is not enough. Because if they are obese, I will give them anywhere between 20 and 40 milligrams of famotidine and Bicitra if it's available. But I definitely use a combination of Reglan and Pepcid or metoclopramide and famotidine for all of these patients. And any patients who have morbid obesity who are undergoing a procedure with or without an endotracheal tube. Now, what are the other anesthetic considerations after bariatric procedure? Now, this is a CT replication of what happens to the abdominal fat after a patient has had bariatric surgery. So the yellow is visceral fat and the blue is subcutaneous fat. Now all of you know that metabolic syndrome is associated with higher amount of visceral fat and not the subcutaneous fat. So it's the visceral fat that produces all the symptoms of metabolic syndrome. And after bariatric surgery, there is definite reduction in visceral fat. So we know that patients have bariatric surgery today and their diabetes is gone within 24 to 48 hours because that fundus is gone and there are neurohormonal changes that actually get rid of the diabetes almost straight away. So there are definitely long-lasting effects in terms of metabolic syndrome because of reduction in visceral fat over the years. Now, what about the upper airway anatomy? What happens to their airway after they lose weight? This is very interesting. So this is pre-weight loss and this is post-weight loss. And this is like supine view and lateral view. So it's interesting to see that they don't necessarily lose a lot of weight in the posterior third of the tongue. Remember, our Malampati classification is, can you see the posterior pharyngeal wall, right? And that is an indirect way to suggest how much tongue fat there is in the posterior third of the tongue. The higher the fat in the posterior third of the tongue, the more difficult it is for us to see that posterior pharyngeal wall. So surprisingly, even after bariatric surgery, that posterior third of the tongue does not lose a lot of fat. So even though your patients might have lost a lot of weight after bariatric surgery, if they were very difficult intubations during bariatric surgery, they may continue to be very difficult intubations during post-bariatric surgery also. And that is the main message that I have for you, that if there were difficult intubations, continue to consider them as difficult, because again, they may lose more fat in the anterior third of the tongue, but it's not the anterior third of the tongue that determines Mallampati. It's the posterior third of the tongue that determines Mallampati. And these are MRI volumes, and the posterior tongue continues to have about 32% of the fat. So changes in tongue fat is the primary mediator of reduced apnea-hypopnea index. So obstructive sleep apnea is determined by apnea-hypopnea index, as you know, and it is the tongue fat. Whenever there's a reduction in apnea-hypopnea index, there's a reduction in tongue fat, which is why CPAP is extremely effective in increasing the upper airway size after in patients with sleep apnea. So just weight loss itself is not effective in taking care of sleep apnea. You need to give positive upper airway pressure for at least 6 to 8 weeks for patients to feel better and increase that upper airway anatomy. So changes in tongue fat happen through that positive upper airway pressure. And surgical reduction of tongue volume does not necessarily have similar results. So we know some patients go for UVPPP, where part of the tongue, but it really does not necessarily reduce sleep apnea. And tongue fat may differentially respond to weight loss approaches that also vary in dietary composition. So if patients continue to take higher fat diets, then they will have higher tongue fat. And preferential reduction in the lipid content of the tongue with the muscle preservation is the only benefit towards AHI, or apnea-hypopnea index reduction. So these are my take-home points, and we will have a good 15 minutes to have a lovely discussion. These patients remain high risk for aspiration. They may have severe esophagitis, so also be very careful with putting in OG and orogastric or nasogastric tubes. They may remain difficult intubation, and they may continue to have obstructive sleep apnea. And thank you for your attention, and we'll open the floor for discussion.
If you have any questions, please go ahead and proceed to the podium. I'm not sure if this is working. Thank you. I can perhaps, I'm definitely riddled with questions for you, so I'll start first. And if you guys have any questions, raise your hand and let me know. But I have so much curiosity, but actually I'm glad you brought up the gastric volume studies that you mentioned in your talk, because I think that the ASA definitely needs to revise their guidelines sooner rather than later, because one, we are seeing patients who are stopping it 1 to 2 weeks. First of all, most patients are only stopping it a week before, because initially endocrinologists refused to even stop it, thinking that it doesn't cause any issues, but now they were willing to stop for a week, and the guidelines came with 1 week. Now I'm seeing 2 weeks. I don't even think anyone is really stopping it for 2 weeks. We are seeing patients with large gastric volumes with that. So we really probably, what I'm hearing from a lot of anesthesiologists and reading, is that we're hoping for at least 3 weeks stopping this medication before they go for surgery. Now, you've mentioned the doses. Your studies are with low doses, which means that the ASA guidelines needs to actually revise it with higher doses too. It should be dose dependent. So if you're on the high dose, which most physicians are actually they're getting tachyphylaxis, so a lot of the patients are on the higher doses. It means it may need to be 4 to 5 weeks of stopping this medication. It should be dose dependent. The other thing is that I think that right now with the current doses, it's just we need to increase those doses, and we need to increase also you said the fasting time. Sorry, I was trying to remember the fasting time. I highly doubt many of our patients are willing to fast for 18 to 36 hours. I see very poor compliance with that. So I don't know if we're actually going to be able to accomplish that. I think the best way is to stop it like a month or 5 weeks prior, because they're going to be much more willing to do that than fast for 36 hours if they're on high doses. What do you think?
Yeah, so from a practical perspective, I feel it will be really hard to stop the medications 2 weeks in advance. It seems the patients will be most inclined that if I'm coming to surgery on Monday, I'll take my last dose on Monday, and
Yeah.
Or it may be easier to say, give us 11 days. So you took your dose on last Monday, and so let's schedule the surgery for Wednesday instead of this Monday. So still the amount of time they are off the medication is still acceptable to them. Or we should say, if you've stopped the medication, if you're on 2.4 milligrams of Wegovy, then you only want to stop it for 7 days, then 36 hours of fasting for solids is the only way. Now, a lot of these patients who have had bariatric surgery in the past or who want to lose weight are on a multimodal approach, and a lot of them do take protein shakes. And so there may be a possibility to say, let's do just liquid diets and 7 days. I don't know the answer to that, but I think we may have to come up with a series of different scenarios that may lead to an empty stomach with these medications.
But most of us, I believe, at least at my institution, are extremely uncomfortable. We're just rapid sequencing everybody who says that they're on these drugs. I don't know how you guys feel, if anyone has any comments on that. But I mean, I think we're going to continue, most of us, to RSI them unless we feel confident that they've actually stopped it for enough time.
Yeah.
And the fasting, too, was appropriate, because with the whole advent of ERAS and how they're encouraging them to drink before surgery, they're calling them and telling them to go ahead and drink their carbonated beverage 2 to 4 hours prior to surgery, not knowing if they're on Ozempic or not. I mean, that just poses a whole lot of slew of other problems that, complicates the picture.
I agree. After 7 days of fasting, 7 days of stopping and more than 12 hours of fasting, we've seen layers and layers of food in the stomach on endoscopy. Yeah. So we know that there is definitely a lot of food, residual gastric content after 12 hours.
Dr. Galler?
I have several questions. If anyone wants to interrupt with one of theirs in the middle of this, feel free. Because, I also watch TikTok videos on people talking about Manjaro and all those types of things, even subsequent to our initial discussion where it became a hot topic. But one of the things that we're seeing is a lot of people that are not significantly overweight, or they maybe they've gotten close to their goal weight and are on maintenance therapy, which is projected to be needed to go to the lowest effective dose, but maybe in perpetuity, as well as there being a controversy where people are looking at people and saying only diabetics should be on this because of shortages and such. One of the challenges I think we face is it becoming something that is a controversy that people may hide because they don't want to be questioned as to why they're on it and why should you still be on it. You look pretty thin to me. But I also think that those that come in that maybe wanted to lose 10 pounds and use this as a tool or whatever, whether we're judging or not, they may not be apt to say that they're taking it because they don't want to have the questions following. In conjunction with that, as we ask them to hold it for 7 to 14 days, if we're already struggling with compliance with our existing NPO guidelines, what is the possibility that people will feel like they're going to either have problems with their glucose control if they're diabetic, but also those that are scared to gain a whole bunch of weight during that time? Is there a place for us to supplant the cessation with extended fasts instead, and maybe couple it with what we really recommend is you holding off on having it from 14 days prior, but alternatively, you either would have to do a 36 to 48 hour clear liquid diet, but if you extend that out to 3 or 4 days, you can stay on the medication, maybe with studies to support it, and continue to reap the benefit, but then maybe it'd even be easier for them to do a 48, 72 hour clear liquid diet so that they have nothing in their stomach.
Mm-hmm. That's definitely a possibility. However, we don't have a single, so the only case report that we have suggesting is one patient, definitely, but who was only on 0.25 milligrams of semaglutide. So definitely, I think we need, moving forward, we need to look at studies for patients who are on higher doses, and then giving them a combination of 7 days, 10 days, or 14 days of stoppage combined with different. It's a different NPO for solids. It's going to be a complex study. Maybe we need to do it stage by stage and in different institutions, all at the
yes.
yeah.
Another question I have is, how do you educate meaningfully about those cessation and NPO guidelines when we're constantly being questioned about? I mean, I do peds, and I have parents upset that their kid who gets hangry in 1 hour of not eating, let alone the 8 hours, and sometimes we actually tack on an extra 2, so there's a wiggle room to move them up if we can, because that's a satisfier. How do we meaningfully give those instructions so they know we're literally only doing it for their safety, and we're concerned that they can't, without morbidity, go through this unless they do it?
So the way I look at this is that it's the solids that are the culprit and not necessarily the clear liquids. So clear liquids are water, apple juice, and carbonated drinks. If we can explain to them that or tea and coffee, black tea and black coffee, and those are all drinks that actually do improve patient safety. So if we ask them to continue the amount of clear liquids that makes them happy until 2 hours before surgery, but stop solids for 18 to 36 hours, that would really change the risk criterion for reduction in aspiration and related morbidity and mortality. We may be able to explain to them that. So in simple terms, what I would say is the medication that you're on increases the chances that there may still be food in your stomach that can go into your lungs and cause severe aspiration pneumonia, which may lead to you going to the ICU or having a longer stay. If you stop the medication for 7 days, we still ask you to continue with clear liquids, which is tea, coffee, and sodas or apple juice, but we ask you to refrain from taking solids for more than 18 hours.
I think that
would that be a reasonable?
It seems like you're partnering with them, and
right?
Saying, this is why, and people really appreciate being treated like the intelligent human beings they are. And you just say, I'm literally just doing it for this reason. I find that they do better with that. When we get questions, it's our schedulers that often that are calling to give the NPO guidelines, and they're non-medical because they're not going. The hospital isn't going to fork out for a nurse to be sitting there calling them to give them the guidelines. So you have somebody that you're trying to help give the right message. And so when we see them or talk to them ahead of time in the perioperative, preoperative assessment, I think that's really helpful because they can take that. Those were the main ones, and I think that the one where people would possibly not tell you or not be compliant for fear of gaining weight back or being judged, I think will be actually a big player in how we approach it.
Right. You bring up a great point about the not so obese patients who just are there for cosmetic reasons or personal reasons. Definitely, there is a big chance that they would be hiding. So we can be open to. We should be open to surprises, for sure.
If I may add, also, I think that there is lack of reporting. So I will just attest that I know definitely the faculty, my colleagues, that they had aspiration with their cases. They're not reporting them. We're not reporting them. We're just, we're talking about it, but it's not being really, we're not really doing, we're not being proactive about reporting it because patients did do well, and so we're okay with it when we talk about it. But it's going to make it very hard to study if not all of us are doing a good job reporting. But correct me if I'm wrong. I believe recently Ozempic has received FDA approval to be used for obesity only, without diabetes.
Correct.
And that's new.
For weight loss.
For weight loss only. So Ozempic is fully approved and will be covered, which will only increase its use.
Absolutely. However, several insurance companies are starting to decline covering, so that may reduce the use
Yeah.
in some ways.
I
There
was.
is a question in the
Oh, there's a
audience.
question. Okay, go ahead.
Okay, the purely elective patient procedure, the patient is not withhold the medication, and you do full stomach content. You assume, and you do a rapid sequence. Now, this is a purely elective procedure. Is it worth the risk? Is it worth the risk?
I don't believe it's worth the risk in a purely elective procedure. But it does require a discussion with your surgeon and the patient. And if the surgeon says this is gastric cancer or this is renal carcinoma, and it's going to the IVC, we need to go ahead. Otherwise, so we can still argue with them that 7 days is not going to make a big difference to the cancer. So it really does require a discussion, and most of us in both academic institutions and private practice are averse to. Yes, sir.
Thank you. Thank you for the amazing talk. So I currently work at a surgery center, so most of my patients are pretty healthy. So a lot of times I don't even see these patients until the day of surgery. So I feel like some of these information really have to come from the surgeons. So I'm just wondering, are our surgical colleagues actually also aware? Because if I don't see them until the day of the surgery and they haven't stopped the surgery, then it comes down to me to cancel the surgery. And how do you deal with that?
That's a great comment, actually. Absolutely, it should be our surgical colleagues who should be identifying these patients in the clinic and giving recommendations in the clinic when they are scheduling surgery. And even in our institution, we haven't taken that step of reaching out to surgeons and saying, "Hey guys, you really need to make this happen." But yeah, that would be the best way to ensure compliance.
I have one last question. Sorry to ask so
No,
many.
go for it.
You really made a great point with your vast experience and expertise in obesity medicine and creating guidelines with how you're giving 20 of Reglan and you're giving an H2 blocker, etc. Do you think that there would be an avenue to have such prokinetic recommendations, just like you would for gastroparesis, morbidly obese? So those that at baseline, you'd already have a suspicion of an increased risk of aspiration, even to just choose which airway you would place, but to maybe apply those in these types of scenarios so that we leverage that prokinesis as well?
Absolutely. Again, a great point. Thank you for asking that. I am a big fan of prokinetic agents. And if you look at Christian Apfel's data, he has actually given 50 milligrams of metoclopramide as an antiemetic to most of his patients. And this morning, and during the PBLD, somebody asked me a question about extrapyramidal reactions. And I have been a big proponent of metoclopramide for the last 25 years of my practice. I used to practice in Australia, where Reglan was a big deal. And in my entire career, I've only seen 2 cases of extrapyramidal reaction. And I've given probably over 10,000 patients this medication. So I think when you combine it with the midazolam we give and other sedatives that we give, the overall incidence is much smaller than what is in our minds and what we fear about. So that's one thing. So definitely, I think we should increase the use of prokinetic agents. The question is how much to give. So 10 milligrams is not going to be enough. For pediatric patients, the dose was 0.4 milligrams per kilo for nausea, and I believe 0.4 per kilo is probably close to about 40 to 50 milligrams, but we should at least give 20 to 30 milligrams for our patients with morbid obesity. And then even famotidine, and even the timing. In one of the hospitals that I used to practice in India, it was a celebrity-only hospital. We gave Reglan and Pepcid to almost every patient as soon as they arrived in the pre-op clinic. Right, so I think it's the timing that matters too. So if that is the first medication that goes in as soon as the IV is placed, you have enough time between the patient arriving and the patient going to the operating room versus we just giving it as we are wheeling the patient back to the operating room. So maybe it should become a standard protocol that any patient who is on these medications should be given these prokinetics on arrival. That's number one. Number two is maybe there, and again, it hasn't been studied, but maybe there is a role in the surgeons starting it in their clinics when they see their patients, because all patients with gastroparesis are on metoclopramide on a long-term basis. So why not also start these patients in the surgical clinics and give them the benefit of the prokinesis and or reduction of gastroparesis, because that's the mechanism that these drugs are working with. Yes, sir. I am not, because that's my recommendation, that we should use Bicitra. But as you know, that most institutions only keep Bicitra in OB floors, and maybe we should make Bicitra available routinely for non-OB floors also. But I feel that use of Bicitra would further reduce the morbidity by reducing the pH of if there is an aspiration, because definitely if the pH is 6 versus 2.5, there will be a big difference in the damage that's caused to the lungs. I would definitely give it, even while we are wheeling the patient back to the OR, I would definitely give it to the patient. Yes, sir.
Hi, thank you for your talk. My question is actually about the imaging modalities. So I just wanted to know, how often is the ultrasound done versus the endoscopy? Because it seems maybe there would be more challenges with ultrasound and endoscopy more like a definitive modality.
Definitely. I mean, ultrasound, first of all, is such a subjective modality, and it gets more and more difficult as the patient have more abdominal fat, so either subcutaneous fat or visceral fat. So it is going to be more difficult to assess the volume exactly of both solids and liquids. So, but we can do endoscopy on every patient. So yes, for research purposes, I think endoscopy is a better way. But for clinical purposes, probably ultrasound still remains the only way we can really assess. And we just have to get better and better. Like we got really good at regional anesthesia. I feel that over the next 5 years, we'll probably get better with gastric ultrasounds too.
It's very ubiquitous. I actually wanted to highlight one more thing also, and I'd like to invite Dr. Boone actually to the podium, because I want her to comment on this too, because we had a discussion about this today. One of the side effects that are now being reported with the GLP-1s is suicidal ideations. And I was doing some reading last night, and the European Medicine Agency is actually investigating. They reported 150 cases in Europe of so self-injury and suicidal threats in patients that are on these drugs. So this drug is right now, I think the Icelandic Society was reporting some of these, and I think now it's under investigation. And I believe you were telling me that some of the drugs are requiring psychiatric evaluations. I would love your input, and along with Dr. Wadwa's thoughts on that, because this is, I think, the new issue that we're having with these medications.
So I practice in the VA, and I feel like everyone is on a semaglutide. And sometimes they're on non-formulary, and they go to their own compounding pharmacy. And so that's not in their med list. They just kind of tell their psychiatrist about this. So I've had several people ask me, several services ask me, not usually anesthesia, but probably endocrine mostly. Do you think this patient is stable enough to be on a semaglutide? So my answer to that is, if they have a previous diagnosis, and my patients have typically a major depressive disorder and or PTSD, probably the most common diagnoses, I look at their regimen, and if they're stable on that regimen, and if they're getting therapy, and if they haven't had any like suicidal ideations or exacerbations. And then I feel like I can make a comment, yes. So I recently had a pretty involved case where a patient had new onset psychosis and was about in the 30s, I believe, but stable on a long-acting injectable, which makes people gain weight. And so we're seeing more and more psychiatric patients on this medication because of those side effects. I felt like I could give the blessing because she was very adherent with her medications, as well as her follow-up and therapy. So it's a little bit of a squishy gray area for psychiatrists. What I'm concerned about is the patients that are case reports in the literature where we don't have a diagnosis of depression, but they become depressed or they become suicidal when they're on the medications.
Thank you. I'm going to take this opportunity. I didn't learn about the suicidal risks until Dana pointed it out to me today, and she probably talked to you today. But I have a practice of giving ketamine to any of my patients who have mild to moderate to severe pain. Except very mild pain, I don't. But I am going to say that we do a service. If we give ketamine to our patients, we are giving a very potent antidepressant to our patients. And I would love the opportunity to discuss this with you as to what does a single dose of ketamine do in the long run for a patient who has either the potential of depression or is depressed?
So I don't think one single dose has extremely long-term effects. We have an S-ketamine clinic, and we are dosing our patients twice a week, and then we are keeping that up for 6 to 8 weeks, and then maintenance doses if they need in a few months. So I personally can't speak to IV ketamine from our clinic, but I can say with S-ketamine you need repeated doses.
And that's intranasal, correct?
Yes.
Yeah. So, all patients who do have surgery have some mood disorders just because of the interruption to their lifestyle. And I feel that, giving 0.25 milligrams per kilo of ketamine in repeated doses throughout the procedure may be doing them a favor in the long run, not just in terms of acute pain, chronic pain, but also depression. So just putting it out there. Also, we had a discussion this morning, and since we are talking about obesity and airway management is always a big deal. So when you use ketamine, it is a great bronchodilator. It maintains your upper respiratory reflexes and actually reduces the chances of aspiration. So one of the considerations I feel that we can do is actually use multimodal induction technique, which would be a combination of SIVO, ketamine, and a small dose of propofol. But again, not for semaglutides, but I'm just talking about morbid obesity.
And now, one last thing, if I may add, I know we're coming towards the end. If someone has any questions, please let me know. But I wanted to just pinpoint, because it's important. I think we're starting to see a new phenomena too with the drugs called, they're naming it sarcopenic obesity,
Yes.
where I think we're aware of it, but we're seeing more lean muscle loss versus fat loss, and that is increasing, causing more frailty in these patients. If you could just finally comment on that, just for the audience to be informed about it, because
Sure.
they're not talking about it as much yet, but it's starting to be more of an issue.
So there is some data that it's the patients with very low body weight or BMI less than 18.5 have a way higher mortality than the patients who are even obese or moderately obese, right? So my theory is that if these patients are specifically losing muscle mass and bone mass, they are nutritionally as bad as the patients who are in the category of less than 18.5 BMI. So they would probably fall in the same category of high mortality with higher surgeries, with high risk surgeries as a very low BMI patient. That's my 2 cents. Again, we have no data on it, but I feel that just because of the body composition status, they may be at a higher risk than a patient with obesity. Because patients with obesity, there's something called obesity paradox, and obesity actually protects patients from dying perioperatively. Mild to moderate obesity, not the super obese and severely obese, but mild to moderate amount of adipose tissue in the body is actually protective from mortality and morbidity. So I feel that patients who are on long-term semaglutides have lost a lot of muscle mass may be at a higher risk.
And I believe it's being noticed more and more when patients are losing a lot of weight in a short period of time because they're upping the doses, and I'm hearing lots of stories of I lost 50 pounds in a month.
That's
This is the group that's at risk of this.
yeah, that's dangerous. Yeah.
Thank you, guys. Thank you, Dr. Wadwa, for an amazing talk. Thank you, everyone, for being here. Please enjoy your break and feel free to evaluate us in the app. Give us an evaluation for this talk, and I hope it was very helpful and informative. Thank you so much.
Thank you, Dana, for having me in this committee, in this meeting, and for 3 years in a row. And I'm really delighted and
Thank you. We're honored to have
for
you.
your.
Thank you. Thank you so much.
Thank you.